Hey, Saibal, how are you?
Hey, how are you? I was looking at the case what Sai is doing.
Do you want to give some critiques? I'll pass them on.
Yes, yes, you
know,
can. I actually saw it. It's good because I basically created a monster over there, but that's okay. He did well.
We're
Huh?
gonna tell him that you disagreed with everything he did.
No. Hey, I actually like the position of the clip.
and
It's a good
actually, you know what?
position.
He even has a pigtail in there, so that's good.
Yeah, I know. That's what I'm saying. So can I introduce? Thanks for allowing me. I was overhearing the beautiful conference. Both the cases were very nice. So we've been here very early in the morning. We're half asleep. I actually had almost a STEMI in the morning. But let me introduce you first to the team. We have Marwa on the left side. She's the our first cardiology fellow. She just started like a month ago. And the first rotation is cath lab, and the first cases are MitraClip. She doesn't know how to do coronary angiograms yet, but she knows about MitraClip.
Sounds like she's
We're
like
starting
you.
backwards.
She's like
Yeah.
you. She's like you.
So we have Mike Limon. Mike, say hi. We have Gabriel Oreda. These are our lead techs. We have Nate and Ali from Abbott, which are going to be. They've always been in my life cases. We have Asma, my PA, and Asma specifically is here in the morning because she's from actually Hyderabad. She was born in Hyderabad. Is that correct?
Yes.
And then she moved here in the US, and she's my PA for like 20 years, and she's going to present the case. We have Jose over there. He's one of the cartels, but he's actually working today. And then on the anesthesia is Gabriel Oreda. Sorry, Andrew Gabriel. Andrew Gabriel is one of the best people that I work with over here. He's a cardiac anesthesiologist, also does transesophageal echo. And with that, actually, Asma, I would like to present this case. We have Kathy in the room. Kathy, where's Kathy? Kathy and Diane, and Sophie from Alta. Sophie from Alta, because Alta is how we are presenting this case, transmitting this case. It's actually an amazing system. Yes, Asma.
Okay, good evening, everyone. I'm in Mumbai. I'm Asma Hussaini. I'm a PA, a physician assistant here, supporting structural heart team. So we have a gentleman here who's an 84-year-old male, a pretty healthy guy. This is the demographic that we serve here. We're about an hour north of Los Angeles, and we have a pretty healthy population. He's 84 years old. He presented with NYHA class 2 symptoms of heart failure over the last 6 months. He becomes short of breath with only incline walking. He has a history of bileaflet prolapse for many years. He has a history of permanent AFib, thrombocytopenia. His platelet count today is stable at 91,000 and a history of hypertension. He has normal EF, 55%, and then moderate to severe MR and TR, and his RV systolic pressure is about 41. His STS predicted risk of mortality was about 3% for mitral valve repair and 4% for replacement. He's considered high risk only because he's pretty frail. He only weighs about 59 kilos. So this is his echo. So I'll have Saibal talk to you about his echo.
So you see, I think he's a mixed pathology of permanent AFib and bileaflet prolapse. He's got moderate to severe MR. He's also got a quite significant moderate to severe tricuspid regurg. Even I was thinking of putting him in the repair MR trial, but I thought that the TR is significant. You can't leave it alone. So we brought him in, and I will show you the pathology. It's a bit tricky. And if you want any comments now, you can make comments. But actually, can you see that you can see there's 2 jets. There's a medial jet and there's a lateral jet. And the valve area is very large. It's about 8 square centimeters. But I want to just show Gabriel showing me the images.
Sure.
So is there any questions from the audience or panel, or shall I just show the images?
Maybe show the images and then we can have a discussion.
Yeah, sure.
Okay. So here you guys can see the 2 jets, and they actually don't communicate in the middle. There's some decent coaptation in the middle there. We'll put it on X plane here. We think kind of the lateral jet is the larger of the 2. And here, if we go more towards the medial jet, you see a piezo jet underneath. I can open it up. There we go. And then we'll just go directly to the 3D on FOSS view here. And you see 2 isolated jets. We've increased the wall filter just to kind of really isolate the high velocity jets here. But in the middle of the valve looks okay.
Give me the clip.
And then we can add multi-view here.
Stop the music. What the hell? Can I have the clip? Yep. Start flushing.
Yeah.
Okay.
Be nice if at some point these all these manipulations could be stored by the Philips software, but currently you have to do it every time. So
So Saibal, what is
Yes.
your thought process here?
So you tell me, I mean, I was thinking initially of going for the medial jet first and then leaving the lateral jet alone. I think the lateral is a bit bigger. So the question is, shall we just go in the middle and put a clip in and then see?
So can I ask, yeah, that was sort of my point. This is mixed
a second.
pathology. There's prolapse, and all you're trying to do is restore coaptation. So if you go in the middle
Wait,
with an XTW and bring things together.
Look at this. Yes, I'm hearing you.
Well, if you just bring in the middle and you do that, will you improve coaptation even if you don't target each jet individually? Would you ever consider that in a scenario like this?
Yeah, I was thinking about that.
I think that was going to be our strategy, and we'll see kind of what we're left, you know.
Because to be honest, I agree that the lateral jet may be a little
no.
bit, but not by much. And there's clearly coaptation between them. So if you went one way or the other, you are still going to need a second clip. But if you went right down the middle, you potentially could get away with one XTW.
That's exactly what we were thinking. Yeah.
So I actually like that idea. And then we can always move it, isn't it?
Yeah.
Especially since we're starting in the middle of the valve, right? Yeah.
So that's what we did. Initially I was trying to do slightly on the medial side, but let's try. What about trying in the middle, and then if not, we can move it a little bit on the side, because when it's in the middle, it's in the cord-free zone. I need the flush.
Yeah, I think that's
Right?
what you're saying, Saibal. Put it in the middle and then we can reassess. But obviously, if need be, you can move it later on, you know.
Yeah. So what we've done already is we've just done the transeptal, and we're now advancing the clip. Can you see live now? Can you make Sophie make echo large, fluoro smaller, and aside? We have an LA pressure. It's like if you can see the LA pressure.
Yep.
Can you show the LA pressure?
Yeah, we see it nicely.
You can see a very large 18 V wave. So its MR, his blood pressure is now 130/63. So I'm just advancing the XT. I took an XTW. Is that okay, guys?
Yeah.
We agree.
Okay. So the transeptal puncture is about 4.5 centimeters. So I'm just going to bring the valve right down. I think it should be okay. So it's very anterior. So I'm just clocking the guide, and that's going around a little bit straight on. So you can see over here, we are actually not too bad now. And can I see BICOM properly?
If you move a little more posterior, you'll see it in there.
Okay.
There you go.
Okay. So that's actually not a bad position, I think, and the trajectory on both sides look quite good, right?
I agree.
So I'm going to open the
You might
clip.
have a little bit of a lateral drive, no?
Yeah, I'll correct it, because usually when you open the clip, it turns to correct it. So
We're about 90 degrees off. it looks
yeah,
like.
so I'm just going to correct it. My fluoro know it's wrong, and so I can see I've already corrected it.
The echo's not good enough here, so.
Okay. So no, your echo is amazing. So we've oriented the clip correctly, right? So let's do 3D end phase.
Sure.
But you're going to check on 3D with orientation?
Yes, that's what we're doing. So you see, he set the home correctly. So that's actually quite nice, right? I think it's okay.
I think it's pretty good. Yeah, we look like we're,
So let's go like that. Now let's test the grippers. So that the blue is posterior, you agree? Dot is anterior.
Okay.
Can I see it?
sorry, Saibal, just making those adjustments
Okay.
again. Yeah.
Is your dive medial or no?
No. We were just he's trying to play. He wants me to do the whole case by MPR.
Okay.
It's up to you. We don't have to.
No, it's okay.
Yeah,
It looks
yeah.
great.
That's what
It's actually
Becky wants too all the time. So
Yeah, I know. So it actually looks good, huh? So I think I should advance the clip.
Yep.
So the dot, remember dot is posterior. No, actually dot, what do you say? Dot is
Saibal, are you happy with your location? You think we're a little maybe touch medial in the BICOM view there?
See, let's just see the color there.
Yeah. Yeah, you're in between the two, so
Yeah, that's
maybe it's
good.
a good spot. Yeah,
Good spot,
okay.
yeah.
Yes, okay.
Huh? Dot, double check. Which one? The dot? Anterior, the blue is posterior, okay, good. So I'm closing the clip. What's the tidal volume?
350.
So the tidal volume is 350. So I'm slowly advancing the clip. Am I right? I'll pull this when I tell you to. Keep. And you see how nice it is by MPR. He's actually showing me the trajectory line.
Yeah.
I'm through the, he was right. There was a bit of a lateral dive. I'm giving a little bit of a medial to it. The clip's moving very nicely. And you don't like the thing to be moving, so I've just block it a little bit. Yeah, that's just a tiny bit, just a tiny bit. Let's stay like that. Good. And then we're just going to open the clip. And we're going to see the orientation.
Can you come up a little higher?
Yeah. Okay. And I'm just going to lock.
I think we rotated a little bit, huh?
We
Saibal?
did? Yes. So we counterclockwise a tiny bit.
Beautiful.
Okay.
Yeah. Great.
Okay. Let's go down. We'll keep. No, block it. See that? How about now? Now it looks good, eh?
I think it looks good, yeah.
So do you like this position, guys? What do you think? Shall we go? This is actually right in the middle now.
Oh, you're caught
Love
on the anterior leaflet. Do you see that?
Anterior.
Yeah.
No,
Okay,
it's-
now you're free. Yep.
Okay.
Good.
All right. So color on and let's see where we are.
Sure.
So we're right in the middle with these jets,
I-
multiple jets.
Yeah,
I think we should just go for this, right?
I agree. Yeah.
Great,
Yeah.
just try and see what you get.
I'm going to close the clip to 120. And I clockwise the guide a little bit. Okay, the anterior got caught.
You're free now. Good. Oh, caught on the cord there, huh?
Yeah, it's getting caught in the cord.
Yeah. Again.
Wow, do you see that? We're actually,
Yeah.
there must be a cord there, which I'm getting caught on.
Yeah.
That's the
That looks good.
wide
now.
clip.
Okay,
there you
now-
go.
now I
That's
got it
nice.
right.
Yeah.
That looks
uh-huh.
amazing.
Right? So let's just drop it here. Both the grippers are down.
Beautiful.
Okay. All right.
Excellent.
The orientation on the right lower panel looks great. So we
Yeah.
should close.
Yeah.
Okay, so I'm just going to close. And we should watch LA pressure as we do that. I've locked the clip.
You can see a bow tie forming already.
And
the
I'm
bottom
actually,
left. Yeah.
Yeah.
Are you seeing any change in your V wave cycle at all?
yeah, the LA pressure's come down a little bit.
Yeah.
Okay, so it's now completely closed.
There's a little play in that posterior leaflet, huh?
Yeah, I think it's okay.
Yeah.
All right. Let's now see color.
Sure. So we'll get out of this to properly assess.
So with,
color.
I think orientation, there's no distortion, right?
Yeah, I agree. There's
That
no
is,
distortion.
The lateral jet's gone,
Yeah.
right?
Do you think you can get any more of that posterior leaflet, or you think you got all of it?
I can come back and just try to play with it a little bit more. You see how the lateral jets become very small?
Yeah.
I like that, right?
Right.
So I don't think I lost any orientation. So I'm just going to go back again, open it up and
We're-
just see how much posterior we have, right?
See if we can get it here.
Yeah.
Yep.
So let's do that.
There's shadowing on the anterior leaflet, but we're mostly on the posterior leaflets here. So we'll just stay this here.
So opening the clip.
Man, it looks like you have a lot there.
I
huh?
think
I
you
have a lot
nice-
of,
Yeah,
Yeah,
big bite
Yeah.
of the posterior.
Yeah.
so, all right, can I see the 3D end face and see that my orientation was correct? Usually the first graph is the best grasp. Okay, the orientation is
Very
perfect,
good.
right? I think we should just take it, eh?
Yeah,
I
I
agree.
agree.
And I think from what I saw of the three jets that were shown at the end, they look like
Yeah.
they're low velocity jets that barely exit into the LA.
Yeah, and you can see how the V-wave became tall when I started. Now, can we close?
Yes, yes, of
Can
course.
you go back to, yeah. Can we go back in LVOT?
Oh,
Yeah.
sure.
Yeah, no, I like this. You do
Okay.
three. Yeah, I like you to play with the multi. It's very good for teaching. So you can see on the LVOT on the top right, and he's going to show it to me. He's actually orienting the plane. It's very good. I think MPR, when you can see them well, see how he's correcting the red line and making it exactly perpendicular. Now you can see the clip, and I can see it very nice. There's a lot of posterior leaflet in, right? I don't think there's any question about posterior not being in.
No, yeah.
So I'm just going to close it very slowly. Nate, do you like it? It's a very nice tissue grasp. Okay, so there's a nice bow tie. I've closed the clip.
Right in
LA
the
pressure
middle
came.
of the valve.
Yeah, right.
Yeah.
And then we can decide what do we want to do now.
I'm sure your
And,
valve is okay. Do you check mean gradient here before release?
Yes, let's do a mean gradient now.
Sure.
So as Sushil was mentioning, we go through the drill, leaflet insertion, which we think all agree is good. Second is MR reduction. Third is mean gradient. Then is pulmonary veins, and then 3D end phase. So let's look at the mean gradient now.
Looks like it's around 4.
Yeah, 160. 3 to 4.
3 millimeters
Mhm.
with a heart blood pressure 132/60 and a heart rate of around 66. So,
Were the veins
Uh,
blunted before?
They were blunted before, yes.
and now they're actually upright.
Co-dominant,
right.
it looks like,
They're,
yeah.
they're co-dominant,
Yeah.
right?
Agreed.
Yes. And can you show the right turn?
Mhm. Yeah, still blunted on the right side, but.
Yeah.
And we check gradient?
Yeah, we check gradient.
Yeah, we're good.
Now
yeah.
let's just look at the color jets. Let's see where we are. I mean, I think I don't want to move it, but we can just get an idea of color where they are because you agree? I don't like to move this.
No, I don't think so. Did you have reversal? I thought you had reversal on the right side before, right?
No, we didn't. No, we didn't have reversal. It was blunted.
Blunted. Okay.
So I think the medial jets are bigger. The lateral
Yeah.
jets are smaller. I
yeah.
would just maybe put another clip medially.
Yeah.
First, just release this and see what happens. I think things may change
Okay,
after you release.
But
it.
everybody agrees to release it?
At least I agree.
I mean, I think so, because again, what is the other, you walk through your
Alternative.
strategies. Your other strategy is to put one medial,
No.
one lateral, and a tri-orifice valve, right?
Yeah, exactly, which I don't think is a nice thing.
Yeah. So I think
I'd
that's-
rather keep the A2, P2 together to restrict the annular size because there's a component of annular dilatation plus
Right.
prolapse in this patient. So I think I would do both. Okay, so I will actually do it and now I'm going to release the valve. The blood pressure has gone up to 149/68. So let's release it. So this is a very high pressure which we're getting.
Can we also bring down the pressure to 120? So some,
No, it's okay. I like to. It's actually good for me to work in high pressure because then I know that I'm seeing the worst case scenario.
No, but to assess MR, I mean, obviously after releasing, I normally would like
It's
to
okay.
bring it down.
I mean, I'm just going to now deploy the clip. Come, Mike. Okay, I'm just tightening the clip. I'm superstitious about this.
Yeah.
I always tighten the clip, over tighten it, and then I just try to open it. And there's nothing there. So I'm just going to go back to positive. And then I, by the way, I'm very happy to have seen the side that was using the pigtail catheter. I really like pigtail LA pressure changes because it's helpful for me to know that that we've done something for the patient.
Yeah, even though G4 can give it, but I think it still dampens when the clip delivery system is there.
yes.
Yeah.
Saibal, can I ask
So
you a
I'm
question?
just
What do
yes,
you
sure,
think,
yeah.
what do you think of G5 without any of this stuff that you're struggling with right now, with no lock line, with none of this in the new version? People like you who've been doing this for so long, it's going to be a very unusual situation.
Yeah, that's what my thing was. That's what I told them that. Like if you start changing the steering to be done on the legs and then the clutch to be on your left, on your right leg and things like that, it's sometimes difficult, right?
Yeah.
Because nowadays I don't even have to bother. I just know exactly what to do. So sometimes relearning things may not be easy, but I don't know.
So the next
We
version,
relearn things.
the
right?
next version of the clip called the G5
Yeah.
will come without this whole business of a lock line.
Okay. So I'm just deploying this now. I find this is already quite good. Getting better results than this. I think where G5 might be of helpful is for smaller atrium, where we have problems here. So the clip has stayed very stable. We've deployed the clip. Counterclockwise your guide limit. Yeah, always open this up and then and counterclockwise. Good. I'm going to take it out. Okay, so let's look at the MR and let's discuss from the panel what we should do next. Right? So why don't you show, while I'm just getting the clip out,
Okay, good.
I want the panel to tell me what you think. The patient didn't want to come in the morning.
No, I
And
understand.
then I told him that Sushil's going to be on the thing. And I might have to discuss about what to do. And he said, oh yeah, then I'll do it in the morning.
Uh-huh. I
Looks
see
like
your
the
sense of
medium-
humor is still
medium-
good early in the morning.
Yeah.
So it's nonstop, guys.
So
right,
what are your thoughts here then, Saibal? What,
Um,
medial,
I don't know,
another, an XT, not an XTW, but an XT?
no more XTWs.
Yeah, XT
So-
though. Would you do an XT?
Yeah,
here?
XT. Yeah, I was thinking of doing an XT medial, but the jet looks lateral, no?
There's two
Okay.
jets. I mean, there's the medial jets, and it looks like that lateral jet kind of appeared once you're released. So
where-
there's this one looks more significant though.
The lateral jet, right?
The medial jet. This
I
is the
see.
medial right here. Yeah.
The
Okay.
medial looks more significant and
Here's the lateral jet. I mean, they're both, I think, worth targeting potentially, but I think maybe you start with the medial.
See, the lateral, the advantage is I can go right close to the clip and get it.
Yeah.
So
Correct.
why don't we do 3D end face and look what it looks like? And then, so let's get anyway, we all agree that we'll need another XT, right? Narrow clip,
An XT for the medial jet.
Yeah.
Yes.
Yeah.
No.
narrow, or even a lateral.
Yeah.
So let's look at them by telemetry. So we got a nice tissue bite.
Yeah.
See,
a lot
there-
of
there-
posterior.
There's a lot of posterior leaflet. The valves now doesn't look that big anymore. Now look at the color. See, my concern is, look, if you look at the medial jet, it's quite
Far away.
far from the clip.
Yeah.
So I think I don't want to touch the medial jet.
Mhm.
I'd rather touch just the lateral jet.
do you want to look
And
at
just-
the
and
gradient
just a-
again or because
So, I mean, also to measure the ERO of both but you're
You see
right.
how it doesn't it look the valve becoming smaller now, like a lot?
oh yeah,
Because it got with such a lot of, but you see, the beauty is that this is good because we know that this will act as an annuloplasty effect, correct?
yes.
When you pull it together so well. So even if we left it like this, it's not the worst scenario.
I mean, and I think that's an important point because what you're also doing is preventing it, during those periods of high blood pressure, hypertension, this is sort of stabilizing it, as you said.
Right. I
Right,
mean,
yeah.
Yeah, I definitely like to measure the gradients, measure the area, and also bring down the pressures because, the patient can be medically treated. We would need to optimize medical therapy in all these
Oh,
patients.
yeah.
Right? So.
Yes, of course.
Definitely, I
So
think.
Saibal, maybe we can go to Sai for a few minutes just to see what he did.
Yeah,
and
sure,
come back
sure. Yeah. Yes.
to- Okay.
Saibal, we're back with you.
Saibal, we're back with you.
Good. So, I want to show you the picture before we go into prepare that we've confirmed we want to go for the lateral jet. As we said, and you can see that, look at that. The lateral jet is not insignificant. The medial jet is really near the commissure. The lateral is close to the clip. So I think with that gradient of 3, I think it's best to go 1 and XT for the lateral jet. You guys see that? You agree with that?
So XT skinny going lateral, right? That's the
Yeah,
plan.
yes. Okay, sorry, clock it. a little bit. That's it, perfect. So you saw that? The clip is ready to go. I've opened the clip and you want to do a 3D end face to
Yep.
orient it.
I am.
So we're just going to orient the clip. And so the advantage, of course, for teaching people, which you guys can tell the audience that fluoro is very useful in the second clip. So he's actually orienting it quite well. I think it's quite well oriented already. You agree? It looks
Close, almost there.
so a little bit of clockwise. Yeah. Okay. So I like that. Okay. So you want to decrease the tidal volume, right?
We're okay, I think.
Okay. So I'm actually going to go slightly inside, and then I'm going to add a little M to be closer. I'm going to test the, so this is, can I see where the clip is? Can you
Sure, yes,
bring it over there? Okay, so let me look at the, I'm wondering why I can't see both the arms.
Let me see if I
That's
can
okay, yeah,
make it
that's-
better. There you go.
Yeah, so maybe I should do a little bit, right? So both the arms can be seen. So let me play with the, so this is the blue is posterior,
Yeah, a little
The-
bit of shadowing.
the dot is anterior, okay? So we've seen the grippers. So I'm going to close the clip and go very close to the first clip, okay? So you agree that most of the time you can use this, you can do a lot of fluoro and guide yourself. So that's what I'm going to do. I'm trying to block the guide a little bit more to make sure I'm in the middle of the valve. And then I'm just going to go very close to that. So I'm very close, right?
Mhm.
I'm going to open the clip. It hasn't rotated, I think. And you want to 3D that. Yep. Increase the gain a little bit. Yeah, I think it's okay, right? Maybe a little tiny counterclockwise, right? Now can I see the clip a little bit better?
Mhm.
So he's showing me, he's putting the blue line on the clip. You can put the blue line on the clip.
Oh, yeah.
Yeah,
sure.
yeah. If
Yeah,
you put the blue, yeah. So see that when you put the blue line on the clip on the left lower, you can see the orientation, correct? So that's the advantage of
Mhm.
MPR, right? And I
Yeah.
think you all agree that the orientation is okay.
Yes.
Looks good, looks
Yeah.
good. And I think
Good.
it's close enough to the other clip too.
Yeah, it's very close. So I don't think it's going to be a stenosis. I'm just going to bring it up as much as I can. And then I'm just, what's happened? What did you say? Close the clip a little bit.
Are you caught or is that the previous clip?
Yeah,
we're
just
seeing?
it's
I
very
think we're-
close.
Yeah, I think we're seeing the previous clip.
And
yes.
then, and I'm just going to drop it down.
I can show you the.
So you're not doing a breath hold, but you're doing very low tidal volumes, is that correct?
Yeah, just very low tidal volumes. So I think I've got it, and I'm just closing the clip.
Right, the concern if you've already positioned the clip and then you take the tidal volumes even further down, when you're happy with the position, you're going to move more medially, right? So
Yeah.
Right.
So you see a nice tight tissue bridge, and you can see if on fluoro, do you see how the second clip is a little bit more proximal than the first clip? Do you guys all see that?
Yep, yep.
Yeah, and that's, you know what does mean? That means you've got more tissue, right? Because the more higher it's getting up means you're getting more tissue. And you can see very clearly there's a lot of posterior leaflet in. So I've closed the clip nice and tight. The air pressure is constant. The blood pressure is 148/70.
you have
And-
a more prominent knot in the bow tie on the bottom
Yeah.
left there,
Like nice, look at that beautiful MPR imaging over there.
almost a double window
Tell Becky that people are learning what she's taught all of us.
Mhm.
So,
All right.
so I see very little. You can go to real time.
Yes,
Yeah.
sure, yeah.
I think leaflet insertion has been no question. Let's look at color in this view because this is the one that shows the best. And you can see there's a very small commercial jet, very medial. That was, we remember. So I think the big jet is gone. You agree with that?
Agreed. Yeah, big jet.
And I'm not going to do anything more. We should measure the gradient now,
Okay,
and then we can deploy the clip.
yeah, I'll just see if we can see insertion here as well, just as one more check.
Do you think we could have got a better result if we just used the Pascal?
No, I
Because
don't.
the
think
Abbott
you
people
can-
are
you
here,
can
he
say
has
that.
to-
I think
Let's see.
half the time you go one way or the other, and you make different judgments, right?
I think Pascal's a better device.
In these type of anatomies too?
He's
No.
joking.
Are you
he's
just
joking.
pimping the Abbott people in the room?
He's just
Exactly,
giving Dave a
yeah,
hard time.
you
He's
you don't know
giving Dave-
Saibal well enough if you.
He's just giving Dave a hard time.
Shaquille knows me very well.
Yeah.
I know him
It's just-
well enough.
Yeah, no, I'm just messing around, sorry.
So,
Right.
you're
I'm
gonna
trying to get-
deploy and then you're gonna reassess the medial, or you've already decided? the
No,
medial is too far
I
away?
think let's get the gradient.
Yeah, this is the medial jet, just so
Yeah.
you guys can see it here.
And I think it's far away. So, well, let's get the gradient first.
Okay.
And if we think the gradient, that's the gradient, okay, that's good.
It's probably gonna be 4 now.
He's-
Yeah,
Yeah, if it's 4 at this pressure, I'm not going to give anything more. His blood pressure is 145/65. His heart rate is 65 a minute. And his gradient is 3.
Yeah.
Okay. We can do MPR and measure it, but let's deploy it and then we'll decide together. Well, how about that?
That sounds
I'm
good.
on I'm really on the fence of doing another clip. And now,
It would have to be further away from your other clip, which you don't like to do.
which I don't
typically.
like to do anyway.
Yeah, right, yeah.
So you can see by fluoro that our clips are very parallel to each other.
And I like
just
the
trying to
motion, first clip now with this one there too, right? You'll see after you deploy, hopefully, they'll be in sync and much more stable with the motion.
Yeah.
Yeah,
So I'm just
it's a
going to deploy
software.
now. So you see the way I do this. I'm just trying to open that clip. I just want to, while I'm speaking, I want to acknowledge that we have 2 techs here and actually 3 of them. The nurses, they prep everything by themselves. They do have some support from Abbott, but they're really good at what they do. And most of the time they do the deployments, which I wanted to show that this is becoming almost a 1-person procedure for us now.
That's interesting, yeah. Can't show it on 0.
So this is the positive side of neutral.
So what Dr. Saibal is doing is he's testing making sure the lock is in and the clips are not, clip arms are not opening, being on fluoro and turning the white knob over there, okay?
The other thing, all of us on the panel, as well as we operators, should acknowledge the role that the clinical specialists of these structural heart disease companies bring to the table, especially I think for MitraClip and even Pascal. They really know the procedure very well. And I always recommend that all operators should actually listen to what they say, because they really, they have seen many more cases than us. And so I always take their opinion. Do you agree with that, Sushil and Ramesh?
Yes.
Ashish?
100%.
Absolutely.
In fact, Nate was used to cover Phoenix, so I know him very well.
Exactly.
Mhm.
Nate's now you're in Pascal, no? No. Okay.
Well, why do you have to be difficult?
I'm not,
Focus on your task. Focus on your task.
I'm just trying to find
He
out
doesn't know any other way.
where. I just don't know where he is, so I just wanted to find out.
Yeah, I mean, a lot of this procedure is decision-making though, right? I mean, the
Yes, I
procedure is
agree.
controlled, it's slow, it's even before the clip goes in, after the clip, the assessment. You rush this and don't go through the making process, that's when you get into trouble.
Exactly.
Uh,
I agree with you. Sushil, 90% of the work in this procedure is planning.
Yeah,
And if you do it
And-
correctly,
Saibal, I
you
want
get
to
away
ask
with it.
one comment, one
Yeah.
question. The way, it was really beautiful how you went and got close to that other clip. It is something
Yeah.
that most people don't do because they get nervous, right? They
Right.
get nervous, they're gonna knock that first clip off.
Yes.
And can you comment a little bit about the technique or if you've gotten into trouble with that? Because it looked like you were alternating with respiratory variation, like when, even those low tidal volumes,
Yes.
to me, it looked like you were advancing when it went
Yeah.
when with respiratory, it went lateral and advanced a little bit, then wait, then advance a little bit. Can you comment on your technique?
So actually, Sushil brought up a very important point for doing second clip procedures. People think second clip procedure, oh, it's easy, you already stabilized. There are a lot of things that can go wrong. And one of them is what Sushil was saying. You can either hit the previous clip or you can
Yeah.
go below the valve and get tangled in the cords, right?
Yeah.
And so both things can happen. So it is very critical. First of all, there is a role for both fluoro and echo in the second clip procedure. So look at the echo, looks really good. And as Sushil said, what I do is I decrease the tidal volume down to a lot. Or what Sushil does is, is completely holding the respirator.
No,
And
no,
then
I don't hold breath anymore. That's when I get in trouble. I do the same thing, with
Okay.
low tidal volume.
You decrease tidal volume. Okay, good.
Yeah.
So we do decrease the tidal volume a lot. And then what we do is we advance very slowly. And I'm watching echo and fluoro to make sure I'm not bumping or I'm moving away and just being very parallel to the other clip. And then not going too deep, just going just below the other clip and then opening it up. Then you can be very parallel. Have you seen how close I am to the other clip?
Yeah, no, and the way they're moving together,
It shows it's stable, and you got a nice tissue bridge. And you can see now there's no lateral jet. There's only a medial jet, and I think this is I'm not going to do anything more now.
Because I think
let's
if you
look-
went chasing that medial jet Saibal, your gradient will go to 7.
Yeah,
So-
yeah, exactly. And you can see where it's coming from. It's coming from the medial commissure.
Exactly.
Now that's crap. That's just to piss me off.
That's it. That's my way of getting back at him for all the
The color-
comments about the echo.
Also, we have to acknowledge that this procedure is very smooth and easy because we have very good imaging. Many of the people on the panel have very good imaging, and this procedure cannot be done by a great interventionist and no imaging. I think there's almost 80% of the work is imaging. Do you agree with that on the panel? And I go to a hospital and they say, oh, we have a G machine and we have a echo guy is actually learning. I said, no. If you don't have good imaging, you can't do this procedure. So I know Ganapati and Sai, he's really good in his imaging. The imaging part is actually so critical. If imaging is seen easy, this procedure is not even difficult. Right? You can be very precise.
Exactly.
Do you agree with that, Sai? I mean, all three of you in the panel?
Yep, absolutely. What do you think about the 4D eyes or 3D eyes and push towards doing these clips? What can you comment on that, Saibal?
So we are a small community hospital. We're not as rich as you, and we can't afford $3,500 for an ice probe. So that's one. Two is that I still think that for left-sided structures, that means atrial appendage and mitral, 3D, the resolution that you get with TE is much higher than you can get with an ice probe. However, there are some unique cases where you cannot get good images.
That's great.
And in those cases, this will be complementary. I still think that there's a bigger role for 3D ice in tricuspid. You agree with that,
It's far
Sushil?
away.
It's in tricuspid more than, because tricuspid is an anterior structure and you don't get the images of the valve that you see in mitral. So I think
Gotcha.
there will be a role for 3D ice for
Okay.
sure. Ramesh, to answer your question, and that will be in tricuspid.
Probably mild to moderate. So it's left.
Can we
Actually,
just
the
have a look
only
at
comment
the
would be that, left atrial appendage, honestly, with pre-procedure CT planning and now with the 3D ice catheter, it is relatively predictable because unlike MitraClip,
More
you can
upright, but
plan it
still,
with the pre-procedure
still
CT
blunted,
and
depending
makes
on
it
the.
very easy to do with the current 3D ice catheter. The price,
That was-
though I
yeah.
agree with, $2,700 or $3,500 for a non-reusable ice catheter may make it a little bit unmanageable for most places.
Co-dominant, yeah.
So by the way, the echo shows that the ST and SNT is codominant. You can actually show those images.
Yeah.
Yeah.
You guys thoughts or?
Yes. So I still do most of my LA appendages by TE. We don't even use, we don't even have a separate imager. We have 5 cardiac anesthesiologists, all can do LA appendage. We have 3 or 4 who can do mitral and 1 does tricuspids.
Yeah.
And Gabriel is probably, I mean, I shouldn't be saying one over the other. They're all very good, but Gabriel is one of the best. And you can see, if nothing else, I think what I did was probably a small part of the procedure. What he showed you guys, those beautiful images came from him.
Yeah, so we switched to ICE for left atrial appendage just because it is easier to schedule patients through the cath lab rather than getting a pre-anesthesia assessment, and which is
I
was
see.
delaying it for 8 weeks for our center. That said, Saibal, there's a question from my colleague here, Dr. Gooddev.
Yes.
I just request you to show us the tricuspid valve. Do we plan to do anything for that?
Yes, actually, that's a great idea. Can Sushil and panel, can we actually, that was my goal, to
Yeah.
show a couple of images of the tricuspid and show the imaging of tricuspid. And our goal is to bring him up for tricuspid if necessary. So can you show some of the imaging plans? So that's the zero. Sure. Why don't you speak, Gabriel?
I
Yeah,
mean,
just
we have
to start
30
out
minutes
kind of
with you more. If you want, we can close the tricuspid too.
No, we're going to put in the triluminate trial.
Oh, okay, wonderful. That's good.
Or actually, we can do a
Pascal.
Pascal on.
Pascal,
Sorry.
my Luminate's closed
Okay, sorry.
or continued access.
Yeah.
But this
So
large
where is it? Just
atria-
a 0 degrees, we just advance the probe deeper into the esophagus to
Yeah.
get rid of the left-sided structures.
So he's showing these images. This is the protocol for that. I want people to see this.
Wonderful, yeah.
And then kind of RV inflow, outflow view, just mostly focusing on the inflow.
It's a very
We can close here.
mostly central jet, but broad.
Yeah, yeah.
Yeah, and he's going to show all the views. So this is the most important view, you agree, for us teaching. This is central. He's doing the RV inflow on the left side and explaining on the right side. And then that's the septal and the most likely anterior leaflet. And go a little bit more anterior and see, show.
Go more anterior. Yeah, so towards the aortic valve, in the left image, you get more septal and anterior leaflets. And if you come more posterior this direction, you get septal and posterior leaflets. So it's important to know when we're actually doing the clip.
Right.
And we can also do some MPR with this. We can get basically a transgastric image from the mid-esophagus.
Okay, so
looks like we can see this. So hit here, get multi-view, lock it, blue plane.
So what he's doing is putting on the left upper is the RV inflow outflow view. On the right upper will become your grasping view. Your left lower will become the deep transgastric view. And then the green line, he wants to put the green line along the commissural plane. So this is a beautiful picture to show you the commissural plane. And it looks like it's almost like a quadrileaflet valve, right?
Yeah. Yeah, pretty prominent septal leaflets.
Yeah.
We see this if you're
Septal
looking in the
leaflet has
bottom left
almost two
image.
cusps.
Yeah, right. Yeah.
Right.
So here and maybe there, and there's anterior and posterior there.
Yep. And can you put color now and show where the
Yes.
jet is? So you can see there's a jet between the septal and anterior,
Right there, yeah.
close to the middle. And there's a
There's a-
smaller jet posterior and
There's-
septal.
Right, yeah. And
So
if you were,
So Sushil, what would you have done? I would have just done septal and anterior.
Yeah, I've gone to the approach that every clip I do, there has to be something interseptal. Because I think
Yes, I agree with that.
every time I don't, I regret it. Even if there's a
Yes,
small
yes.
jet, I usually put anteroseptal and then consider a posterior after.
Later, yes.
But
So this one, and why don't you do just for the teaching sake, he's going to show the transgastric, but we don't, let's show this. This has become a critical view for us, though with MPR, you can get it also, but look at him showing this view. And I want you to show the scallops, which is really beautiful pictures. Put color, not yet.
right, yeah, almost, huh?
Yeah, get
There,
it.
I just advanced the angle. It's
Yeah.
always somewhere between 30 and 60.
Okay, so now it looks great. So there,
there's the
yeah,
jet,
that's
yeah.
beautiful.
Yeah.
Yeah.
So you can see, as Sushil said, look, we have to put something between the septal and anterior, and then we should put one close to the canyon. So I think we can put one like almost 2 o'clock, 7,
yeah,
7 o'clock.
2:07 or 2:30. Yeah.
And then the second one can be just 3 and 9, just on the top,
Yeah.
right?
Yep.
Right? And they
Yeah,
can
this
be
looks
both
like a
of them.
very good candidate for edge-to-edge repair for the tricuspid. So
I mean, you think the Pascal would be better for this patient?
only if it's in your hands.
I mean, if you, no, we'll send the patient to you. He'll fly to New York.
So no, the question is though, you'll bring patient back at 30 days. instead of
Actually,
simply-
Sushil, I would ask you a provocative question.
Yeah.
Would you, based on the anatomy that you saw, and this is something for the audience, would you consider this patient for edge-to-edge repair or a TMVR?
Tricuspid?
Sorry,
Tricuspid?
TTVR.
So I have my bias now. I mean, I think in a patient like this, who's a good edge-to-edge candidate with mobile leaflets, gaps aren't too big.
Yes.
My preference is edge-to-edge. I think in patients with torrential TR, broad jets, broad gaps,
Yeah.
you know, then the likelihood of a good result with edge-to-edge is less. And then because with TTVR, you do take some additional risks of bleeding complications because you have to remain on anticoagulation. Granted, most of these patients already are, but then you also have the pacemaker risk and you have some durability issues. So, you know, I think in a patient like this, where with mobile leaflet, small gaps, I think you'll get a great result with edge to edge. So that would be my direction.
Direction. So you would prefer to do any one of the edge-to-edge repair over. So when you, because I mean, the reason why it's good to hear, the audience should to hear what Sushil is saying. I mean, Sushil is the national PI of the TTBR trial, as well as he also does both. He was very much involved in Triluminate as well as in Pascal. So it's very nice to hear a neutral opinion from him on this case to show that it's going to be a choice between repair and replacement in tricuspid, right?
Yeah.
And you feel is it a better way to say, like, if a valve is repairable, you'd rather repair it?
No, and I think
Can I go?
it's also what are your goals in a patient, right? You know, we don't know that with mitral and part of it becomes to what population are we treating? You know, we're not worried about what will happen over the next 10, 15 years in the patients that we're treating. This is population about stabilizing symptoms, managing heart failure, allowing diuretics to work. You know, down the road that may change a bit, but you know, you get to less than moderate or moderate. That's a success in these patients. In a patient like this, though, I think you'll get to mild.
Yes, yes. Now, can I see the appendage once before you go? Because I'm going to consider closing his appendage off. Can you measure? See, not today. We're trying to put him in the laminar trial, which is a new study of excluding the appendage by twisting the appendage. So I want to consider him for that. So can you just measure the appendage in a few views? Are you guys aware of the laminar trial?
Yes.
You know them. Yes.
Yes, we are.
So it's a new way of twisting the appendage. And so what we do is we want to use an appendage so long as it's less than 27 or 28 millimeters, it's actually a good candidate. I just did a figure of a perclose on the groin, and I'm reinforcing it with one figure of 8 stitch while I'm talking. And actually, I want to show the appendage imaging. So what are you getting as the?
Got a 15 and 19.
Okay, good. And what about the depth? It's important to get an appropriate depth in this patient.
19 there in the 45.
Okay.
Same level there. 18. And depth.
Well, the depth will be difficult to measure on in that views. You can get it on 90 degrees also. Try to get, yes, see. Yeah. Actually, you know, the right way to do is the way you do it is do by MPR. You can actually do MPR. And do
So Saibal, I think we're going to wrap up soon here.
22 for the length.
yeah,
Yeah.
we're done over here.
So
I just can I on behalf of all the people in the room, can you show the camera large? I want all of the staff, Jose, Nate, Ali, Gabe, Mike, Asma, Marwa, and Gabriel, and Kathy, and Diane, and Sophie. I want to say thank you. I do also want to acknowledge at the end, and since Sushil has it, so I want to talk about the system of transmission. This cost very minimal money. We actually have a system called Alta, which is inbuilt, and all we have to do is a Zoom link, and we can transmit images. Sushil has it in his lab, and they're coming up with some amazing software stuff and technology for TAVR. So this is a beautiful system. Do you agree with that, Sushil?
I
And this
agree.
is-
I don't know how Sophie gets any rest, and she supports our system as well on the East Coast, and now she's out on the West Coast.
She's moving to LA.
Oh, all right, fine. So anyway, so I want to thank you, and I want to thank especially not just you, but your staff, because I know they had to get in very early, and I know how challenging it is to do that and with live cases, and your patient as well. And it's remarkable that you have a team that's willing to come in early and to do this and for transmission education. So I want to thank you and your entire.
And please
team on behalf
thanks
of JWCC
Srinivas.
India.
Srinivas specifically.
Srinivas is-
I let him down last time. I'm sorry, but I didn't want to let him out this.
I'm Dr. Srinivas here, Saibal. We all loved you and we tolerated whatever you did last time, no problem. But we are thankful to you for making it possible for this year. And thanks for an excellent demonstration.
Thank you.
Thank you very much for your cooperation.
Thanks a lot.
Take care,
Thank you.
Saibal. Have a good night.
Thank you.
Thank you.